Every 40 seconds, somewhere on this planet, someone suffers a stroke. By the time you reach the end of this sentence, another brain has been struck. Each year, stroke claims nearly 6 million lives worldwide, ranks as the second leading cause of death globally, and stands as the #1 reason people end up with permanent disability. The part nobody spells out clearly enough. In a vast number of cases, the brain delivers very specific warnings hours or even days before the major stroke arrives. You simply have to know what those warnings look like. What stroke actually is. Stroke is not simply a matter of you were fine, you collapsed, you woke up in a hospital bed. In most instances, stroke is the foreseeable endpoint of blood vessels that have been deteriorating for years. And if something is foreseeable, it is at least partly avoidable. That is the entire purpose of what I am sharing today. When people use the word stroke, they are actually referring to two very different events inside the brain. The first is a hemorrhagic stroke. A blood vessel in the brain ruptures. Blood pours into or around the brain tissue, forms a clot that compresses the surrounding structures, and a significant proportion of those patients die. The second is an ischemic stroke. The vessel does not tear, it gets blocked. Blood flow to a section of the brain ceases, and brain cells in that zone begin dying within roughly 4 to 6 minutes. Ischemic strokes account for approximately 85% of all strokes. That is, the type I am going to concentrate on today. Why every minute counts. To grasp why time is so critical, you need to appreciate just how demanding your brain truly is. It weighs roughly 1.4 kilograms, about 2% of your total body weight, yet it consumes around 20% of the oxygen you inhale and approximately 25% of all the glucose circulating in your blood. It is a command center that never shuts down, and it requires an uninterrupted fuel supply. Sever that supply for even a few minutes and cells begin dying in ways that cannot be undone. That is why physicians say stroke is a race against the clock. It is literally a race to rescue brain tissue before it is lost permanently. Here is what most people overlook. For a brain artery to suddenly block, the groundwork was almost certainly laid over years. The vessel walls have been sustaining damage, cholesterol and clots have been accumulating, and the opening has been steadily narrowing. This is not an explosion from nowhere. It is the final step of a long process. Along that road, your body typically sends out warning signals. The trouble is that nobody ever taught you how to recognize them. The warning shots, transient ischemic attacks. In medicine, those early alarm bells are called a transient ischemic attack, or TIA for short. Transient simply means temporary. It arrives and it passes. Imagine a carotid artery, the main vessel in the neck that carries blood from the heart up to the brain. Over years, a fatty plaque forms on the inner wall right at the point where the artery branches. The opening gradually narrows. Then, at some moment, the already constricted vessel goes into a brief spasm. Blood flow halts for a few seconds or a few minutes, and the brain territory fed by that artery essentially blacks out for that short interval. You see or feel a stroke symptom. Then the spasm eases, blood flow resumes, the symptom fades, and you convince yourself everything is fine. What the research actually reveals is that a transient ischemic attack very frequently precedes a full-blown ischemic stroke, typically within the following 72 hours. Those 3 days are your window in which the catastrophe can still be headed off. Most people squander that window because the warning episode was brief, bizarre, and then disappeared, so they talk themselves out of treating it seriously. These episodes usually last anywhere from about half a minute to roughly 10 minutes. That is precisely why they slip through the cracks. You can be in your kitchen, in the shower, climbing out of a car, and by the time you pause to think, the symptom is already vanished. But each of those episodes is your brain delivering a final, unmistakable message. I am about to be in serious trouble. Let me walk you through the 5 major red flags and explain not only what they look like, but what is actually happening inside your body each time. Warning sign 1. Temporary blindness in one eye. You get up, head toward the kitchen, and without warning, one eye goes dark or foggy, as though someone drew a black curtain across it or smeared the lens with gray mud. You blink a few times, maybe rub the eye, and within seconds or a minute at most, your vision returns. So you chalk it up to standing too quickly or too many hours in front of a screen. In reality, that curtain is almost always a tiny clot or a small fragment of plaque that broke loose from the wall of your carotid artery, traveled upward, and briefly plugged the artery that supplies the eye. The artery to your eye is not some isolated, unrelated tube. It is a direct branch of the internal carotid artery that feeds your brain. When the clot or plaque fragment wedges into that tiny ocular artery, blood cannot pass through. The retina, the light-sensitive tissue at the back of the eye, loses its blood supply for a moment, and instead of a clear image, you see darkness or a smear. When the clot drifts free and blood flow restarts, vision returns and you feel fortunate. And you were fortunate, because that very same clot could have veered 2 millimeters to the side, into a brain artery. And then, instead of a 1-minute blackout in one eye, you would be facing permanent loss of speech, paralysis of an arm and leg, or death. Physicians have a classic Latin term for that one-eye blackout, amaurosis fugax, which translates literally as fleeting blindness. Neurologists treat that phrase like a fire alarm. If a patient describes an episode fitting that description, they receive urgent evaluation, because the risk of a true stroke in the coming hours is high. Hospital records reveal a recurring pattern in which a person dismisses 2 or 3 of these eye episodes, and the very next one is the major event in the brain. Warning sign 2, sudden numbness or tingling on one side of the body. The medical term is paresthesia, but you can think of it as your skin behaving as though it is intoxicated. It can affect the entire arm, just the hand, half the face, or even one full side of the body. It feels like pins and needles, like cotton, or as though that body part has turned to rubber. The defining feature is that it arrives out of nowhere, while you are simply sitting, walking, or talking, lasts a few minutes, then resolves on its own. You have probably slept on your arm at some point and experienced numbness from nerve compression that clears up once you shift position. That is different. In that case, your brain and spinal cord are perfectly fine. You simply squeezed a peripheral nerve, and once blood flow and positioning normalize, sensation returns within a minute or two. With a TIA, the problem is not in the arm. It is in the brain region that maps sensation from that arm, and the episode has nothing to do with how you were positioned. One additional detail worth noting: stroke symptoms are typically one-sided because each brain hemisphere controls and perceives the opposite side of the body. When both hands go numb symmetrically, that more often points towards cervical spine issues. But sudden one-sided numbness that resolves after a few minutes is a strong reason to be evaluated for TIA and stroke risk. Warning sign 3, a sudden loss of coordination. What people describe as a drunk walk without having touched a drop of alcohol. You are on a flat, familiar surface, and out of nowhere your foot lands in the wrong spot. Your leg feels weak or rubbery, or you lurch into the wall for a moment. Or you are struck by a sudden, intense spinning sensation that makes you grab a chair or a door frame. Even though you were not spinning, you did not jerk your head, and you did not just rise from bed. The part of your brain responsible for maintaining balance and coordinating fluid movement is called the cerebellum. It sits low in the back of your skull like a compact secondary brain. It continuously calculates where your body is in space and how much force each muscle should generate, so you walk in a straight line instead of weaving. The cerebellum receives its blood supply from arteries that travel up through the bones of the neck into the back of the head, what doctors call the vertebro-basilar system. If blood flow through those arteries drops sharply, even for a few seconds, the cerebellum essentially glitches. That is when you suddenly veer sideways, misstep, or experience violent dizziness for no apparent reason. In clinical practice, there is a well-documented pattern in which people dismiss these episodes as bad footwear, fatigue, or blood pressure fluctuations, only to learn later that they were cerebellar transient attacks. Benign dizziness usually has a clear trigger: rolling over in bed, turning the head quickly, a known inner ear condition. But spontaneous, intense dizziness, accompanied by any difficulty walking in a straight line, should be treated as a possible TIA until a physician rules out a vascular cause. Warning sign 4, sudden speech breakdown. Before we go further, I want to clarify something. If you occasionally cannot recall your neighbor's name, or you temporarily lose the word for toothbrush, that is not a stroke sign. That is a normal tip-of-the-tongue phenomenon that becomes more frequent when you are tired or under stress. What alarms neurologists is something quite different. when your speech suddenly deteriorates so severely that even you sense something is seriously wrong. There are two principal speech regions in most people's brains, both typically located in the left hemisphere. One region, commonly referred to as Broca's area, governs word formation and sends precise instructions to the muscles of the tongue, lips, and jaw. When that zone loses blood flow, you may comprehend everything people say, you know exactly what you want to reply, but you cannot get the words out. They emerge slurred, chopped, or jammed. The other region, commonly called Wernicke's area, handles speech comprehension and organizes your sentences so they make sense. When that area is compromised, a person may speak fluently but produce complete nonsense, like word salad, and may fail to understand simple phrases directed at them. If any of those speech disruptions appears suddenly and then fades after a few minutes, that is classic TIA territory, not "I was just tired." You cannot dismiss broken speech simply because it corrected itself. That is like your house alarm sounding, stopping on its own, and you deciding it was probably nothing. Warning sign 5. Vitiligo combined with new, unusual headaches. This one is less obvious and surprises most people. Vitiligo, patches of pale or completely white skin where pigment-producing cells have ceased functioning, is an autoimmune process, meaning the immune system begins attacking your own pigment cells as though they were foreign invaders. When the immune system misfires in that way, it often does not confine itself to one organ. In many individuals, that same autoimmune activity can quietly inflame the inner lining of blood vessels as well. That inner lining is called the endothelium, a microscopically thin layer of cells that coats the interior of every artery like an ultra-smooth, non-stick surface. When the endothelium is healthy, blood components glide past and nothing adheres. When it is damaged by inflammation, it becomes rough and scarred. Substances begin to cling: cholesterol, platelets, various inflammatory proteins, forming the seeds of plaques and clots over time. Vitiligo on its own does not condemn you to a stroke. But if on top of it you develop frequent, unusually intense headaches that do not match your normal pattern, that combination warrants a proper vascular evaluation rather than a wait-and-see approach. Headaches in general are tricky because many people blame vascular problems when the actual source lies elsewhere. A very common cause of daily or recurring head pain is wear and tear in the small joints between the second and third neck vertebrae, essentially cervical arthritis. That joint degeneration can irritate nearby nerves and project pain upward into the head, which has nothing to do with a blocked brain artery. Beyond that, many people carry an undiagnosed cervical disc herniation. And if it is never addressed, in severe cases it can threaten the nerve supply to the arms or legs. Headaches should not simply be numbed with painkillers indefinitely. They need to be decoded with a physician, particularly when they change character or appear alongside other warning signs like the ones I have just described. What actually destroys your blood vessels from the inside? This is where one of the biggest myths lives. The myth: my cholesterol is normal, so I am safe from stroke. Stroke risk is not solely about what is floating in your bloodstream. It is very much about the condition of that endothelial lining on the inside of your vessels. Recall the non-stick pan analogy. While the coating is intact, food does not cling. Once you scratch and damage it, everything starts sticking and burning. The first major threat to the endothelium is chronically elevated blood sugar. Glucose is your cell's fuel, but to cross from the blood into endothelial cells, it requires insulin, the hormone that essentially unlocks the door into the cell. When your body does not produce enough insulin, or your cells grow resistant to it, you can have abundant sugar in the bloodstream while the vessel lining cells are still starving. Starving cells sustain damage, lose their shape, and can even detach from the inner surface, leaving behind rough, scar-like patches. Those scarred zones cannot constrict or dilate properly when blood pressure fluctuates. Physicians call that a loss of vasomotor reserve, meaning the vessel has forfeited its flexibility. And those rough spots become ideal landing pads for LDL cholesterol, platelets, and other blood components. Over time, these deposits mature into the plaques that narrow and stiffen your arteries. This process begins years before anyone officially labels you diabetic. Even mild prediabetes, where glucose is only marginally above normal, is sufficient to injure the endothelium quietly over a long period. The second major vascular threat is smoking. Cigarette smoke contains thousands of chemicals, dozens of which are established carcinogens. But for stroke specifically, The concern is their effect on the endothelium and the blood itself. With every cigarette, toxic compounds strike the inner surface of your vessels and cause direct chemical damage and inflammation. Simultaneously, nicotine and carbon monoxide make the blood thicker and stickier, increasing how readily platelets aggregate and how easily clots form. Pair a damaged, inflamed vessel wall with thick, sticky blood, and you create ideal conditions for a clot to seal off a brain artery. That is why smokers face roughly 2 to 4 times the risk of ischemic stroke compared with non-smokers who have similar cholesterol and blood pressure profiles. Blood pressure adds another layer of complexity, because the myth here runs in the opposite direction. Many people have heard that stroke stems from high blood pressure, so they dread a high reading and breathe easy when the number is low or normal. Chronically elevated blood pressure absolutely is one of the most potent risk factors for stroke, because over years it physically batters and weakens vessel walls and accelerates plaque formation. It is also the primary driver behind hemorrhagic strokes, where a vessel literally bursts. There is a twist, however. An ischemic stroke often strikes not at the peak of blood pressure, but at a relative low point. Imagine a brain artery that is already narrowed by more than half because of a plaque. It is like a water pipe someone has squeezed in the middle. As long as the pressure in the system stays high enough, some flow still pushes through that tight segment. But if overall pressure falls, the flow through that narrowed stretch can drop to nearly zero, especially if a small clot becomes lodged there and the system lacks enough force to push it along. At night, while you sleep, blood pressure naturally dips by roughly 15 to 20%. This is a normal physiological phenomenon, not a disease. But if you already have a plaque-narrowed artery, that nighttime dip can be enough to convert a partial blockage into a complete one, particularly if a clot has formed on that plaque while you were lying still. That is one reason some people go to bed feeling perfectly well and wake up with stroke symptoms, or someone discovers them that way in the morning. Age and stroke, not the simple story you have heard. Age plays a role, but not in the simplistic, stroke only happens to old people way you hear at family gatherings. Yes, stroke risk climbs significantly after about 50 and roughly doubles with each additional decade. In older adults, the dominant culprits tend to be atherosclerosis, plaque accumulation, alongside long-standing high blood pressure and heart rhythm abnormalities. But approximately 10 to 15% of strokes occur in people younger than 45. In those younger patients, the records show different drivers: congenital vessel malformations, bulging weak spots in vessel walls called aneurysms that can rupture, clotting disorders, autoimmune diseases, and trauma to the head or neck. Another point worth understanding: the speed of vascular damage from the same risk factors shifts with age. After about 40, plaque buildup and endothelial injury from factors like smoking, high sugar, or high pressure tends to advance roughly twice as fast as it did during your 30s. That is one reason physicians become more direct about risk factor control as patients move through their 40s and 50s. What to do if you have had even one warning episode? Now for the most practical part. What do you do if you have experienced even a single one of those 5 warning episodes, even if it felt minor and disappeared in under 10 minutes? You have roughly 72 hours in which a great deal can still be done to prevent a full-blown stroke. The objective is not to panic, but also not to waste that window. Stroke specialists frequently emphasize how important it is not to be completely alone after a suspected transient attack. This is worth planning ahead with your family and your physician, particularly if you live by yourself. If another, more serious episode occurs and you suddenly cannot speak or move, you need someone who can witness it, call emergency services, and reach you quickly. Many people find it helpful to inform a close contact about what happened and ensure someone can get to them easily over the following couple of days. That is a reasonable topic to raise with your healthcare provider. Clinical guidelines also advise against driving yourself after a possible TIA. Losing vision or arm control for even a few seconds at highway speed is life-threatening for you and everyone around you. It is worth discussing ahead of time with your doctor what transportation arrangement makes sense in your situation, so you are not tempted to simply get behind the wheel. Checking blood pressure is usually among the first steps in virtually any acute situation. If you or someone near you can take a reading and the top number, the systolic, is around 180 or higher, and the bottom number, the diastolic, is around 110 or higher, that fits the picture of a hypertensive crisis not merely elevated blood pressure. A crisis at that level is itself a powerful warning sign for stroke, and calling emergency services promptly is what standard guidelines generally recommend. Ask your doctor explicitly about this threshold so you know in advance when to treat it as an emergency. One rule from stroke medicine is absolute. Never start blood-thinning drugs, aspirin, anticoagulants, or similar medications, on your own based on a friend's suggestion or something you came across online. There are two principal types of stroke: ischemic, where a vessel is blocked, and hemorrhagic, where a vessel is bleeding. Thinning the blood can help in certain ischemic scenarios, but in a hemorrhagic stroke it can accelerate and enlarge the bleed, which can kill a person more rapidly. The only reliable way to distinguish between the two is brain imaging, usually a CT scan performed in a hospital. No physician can examine someone and be absolutely certain which type is occurring without a scan. So, rather than self-treating, the right course is to get evaluated and let a medical team decide. You can certainly ask your doctor in advance how they would want you to act if you ever suspect a stroke. While waiting for help or en route to care, body position matters. Lying down is generally preferable to sitting bolt upright because it supports blood flow to the brain. Many clinicians suggest a comfortable flat position with the legs slightly elevated above chest level to aid circulation and ease the heart's workload. The head should be neutral, not bent sharply forward and not thrown back, so that the neck vessels are not kinked. It is also sensible to avoid smoking, alcohol, or exposure to hot baths or very hot showers in that moment, since sudden vessel dilation in an already unstable circulation can worsen the situation. Confirm this with your own physician. Having a written list of every medication you take regularly, kept somewhere easy to locate, is a small step that can save precious minutes for emergency teams. And one point many people get wrong: if 72 hours pass with no new episode, that does not mean you are in the clear. It means you were given a second chance, and you still need to act on it. 3 tests worth asking about. There are 3 evaluations that are very reasonable to request at your next medical visit if you have experienced any of these warning signs. Each one examines a different piece of the stroke puzzle. The first is a carotid duplex ultrasound, a specialized ultrasound of the neck arteries. Unlike a basic ultrasound that merely displays structure, duplex imaging reveals both the anatomy of the artery and how blood is flowing through it, including whether the flow accelerates and becomes turbulent at a narrowed segment. If the carotid artery is narrowed by more than roughly 70% by plaque, doctors call that a hemodynamically significant stenosis, meaning the narrowing is severe enough to seriously compromise blood flow. At that point, the question shifts from, will a stroke ever happen, to, when will it happen if nothing changes? That is why surgeons may propose a procedure called carotid endarterectomy, in which they open the artery and remove the plaque. It sounds dramatic, but in modern practice it is a routine operation that spares tens of thousands of people from stroke every year. If you have risk factors or symptoms, asking your doctor about a carotid ultrasound is a reasonable conversation to initiate. The second is a blood test called glycated hemoglobin, or HbA1c. This measures ordinary hemoglobin, the oxygen-carrying protein in your red blood cells, that has sugar molecules bonded to it. The higher your blood sugar has been over the preceding months, the greater the proportion of your hemoglobin that becomes sugar-coated. That is why this test reflects your average blood sugar over roughly 3 months, rather than a single morning snapshot the way a fasting glucose test does. You cannot produce a favorable HbA1c with one perfect fasting result the day before the blood draw. It is particularly effective at catching that gray zone called pre-diabetes, where sugar has been elevated long enough to damage vessels, but nobody has applied the diabetes label yet. The thresholds are clear. Glycated hemoglobin below about 5.7% is considered normal. 5.7 to 6.4% falls into the pre-diabetes range, and 6.5% or higher typically meets the criteria for diabetes. If you have never had this test or it has been years, it is an easy topic to raise with your doctor, especially if you carry any stroke risk factors. The third is Holter monitoring of the ECG, in plain terms, a 24-hour heart rhythm recording. Instead of a 10 or 20-second electrocardiogram captured in the clinic, you wear a small device for a full day while going about your normal activities. The logic is straightforward. Some dangerous heart rhythm disturbances come and go. They might surface once or twice a day for a few seconds and be completely missed by a brief snapshot ECG. The single biggest rhythm culprit for stroke is atrial fibrillation, or AFib. In AFib, the upper chambers of the heart, the atria, stop beating in a steady, organized fashion and instead quiver chaotically, sometimes at rates of 300 to 400 contractions per minute. When that occurs, blood does not drain smoothly from the atria. It churns and swirls instead of flowing. And in that swirling blood, clots form very easily. Those clots can be ejected from the heart, travel up to the brain, and lodge in an artery. That is called a cardioembolic stroke, and it tends to be severe. Many people with atrial fibrillation experience no dramatic symptoms. At most, they notice occasional skipped beats, brief flutters, or they attribute the sensation to stress or caffeine. Holter monitoring is what captures these hidden episodes. If AFib is detected, there are well-studied medications called anticoagulants, blood thinners, that, when prescribed and monitored properly, can reduce the stroke risk associated with this condition by roughly 60 to 70%. That is not an inevitable fate. That is a risk you and your cardiologist can actively manage. The bigger picture. Stepping back, stroke is not a bolt of lightning from a clear sky. It is a foreseeable event that usually follows years of silent vessel damage, and it frequently announces itself in advance. You now know the major warning signs: brief blindness in one eye, sudden one-sided numbness or tingling, abrupt loss of coordination or an unexplained drunk walk, sudden serious speech breakdown, and vitiligo combined with new, unusual headaches. Any of these appearing for the first time, even if they vanish within a minute, is a reason to speak with a doctor urgently and ask about those 3 evaluations: carotid duplex ultrasound, glycated hemoglobin, and Holter ECG monitoring. On the prevention side, research consistently ties certain measures to lower stroke risk. Keeping blood sugar in a healthy range and catching prediabetes early protects the endothelium and slows plaque growth. Managing blood pressure with your doctor's guidance, not just forcing it down at all costs, but avoiding both extremes, reduces strain on your vessels and lowers both hemorrhagic and ischemic risk. Quitting smoking, with professional support if needed, removes a constant chemical assault on your arteries and cuts your ischemic stroke risk by roughly a factor of 2 to 4 over time. And the single most important takeaway? Do not wait for brief brain symptoms to resolve by themselves. In the world of stroke, you have about 72 hours to act. What to do after reading this? If you recognize any of the 5 warning signs from your own experience, even from months ago, write them down in plain language and bring that list to a doctor. Do not rely on memory. Ask directly whether you should be evaluated for transient ischemic attacks, and whether carotid ultrasound, glycated hemoglobin, or Holter monitoring makes sense in your case. If you carry risk factors like elevated blood sugar, high blood pressure, a smoking habit, or autoimmune conditions, use what you have learned here to have a more specific conversation with your physician about stroke prevention, rather than walking away with a vague, "everything looks fine," and no actual numbers. Everything I have covered today is intended for your understanding and education. Your situation is specific to you, and using this as a starting point for a real dialogue with your doctor will always be more valuable than trying to manage things on your own. I am Dr. Dan Carter. Take care of yourselves. I will see you in the next one.